Oh,
There we go. So welcome to Forthright, and I have a special guest today is Representative Joe Schmick. I've known Joe for quite a while, and he is now my representative since the Lincoln County has shifted once again to a new legislative district, the 9th legislative district. And welcome, Joe, and I invited you here to talk about healthcare.
well, thank you. And we're thrilled to have Lincoln County. Um, I know people there think, well, they're the county nobody wants. Well, everybody wants you. And
Yes.
so that we fight over you. And so we happen to be fortunate enough to be able to represent Lincoln County, and I do consider it an honor.
Well, I'm glad to have you as my representative. I know when we first met, you were new to the legislature and you were assigned to healthcare, and I believe you told me you told everybody, I don't know anything about that, but you have since become somewhat of an expert.
Um, yes, a funny story about that. That was our leader, Richard DeBolt, came to Colfax and he asked me, I want you to lead healthcare. And at that time, I had been on an insurance trust. And so I had managed that trust. And that was the extent of my, other than being a consumer and having to buy it, that was the extent of my knowledge. And I told him no 3 times that no, I wasn't interested. I don't want to do that. And on the fourth time, I relented and I said, okay, I will do what the caucus needs me to do. And no, I didn't know a lot about healthcare, which just means you dig in, with both arms and legs and learn as much as you can. And I'm still learning every day.
Well, I actually think that's an advantage to you coming into it because it is very complicated, and anybody who's been kind of immersed in it for a long time, the longer you're immersed in a specialty field like that, the harder it is to ask questions that are more penetrating or more questions of curiosity. And I think that's something that you do bring to this. And so you were serving on the Universal Healthcare Work Group, and you're now on the Universal Healthcare Commission. And that was why I wanted to hear more about that. So
Well,
tell start wherever you want to start.
okay, several years ago, and it was prior to the pandemic, there was a work group formed. And I think that they did that, the Democrats did that to basically throw a bone to the people who wanted uh, universal healthcare, single payer healthcare, government run healthcare. And so we went through that work group process. Well, the people who wanted this, they took that as people want this and they want it. And they've really started to work very hard. And now there's quite a movement to move us to a single payer healthcare plan in our state. Now, the work group ended, and there was a report that was given to the legislature, and I I wrote in my comments on there that I didn't think this was a good idea, and I think I wrote a page or two of comments about the process. But then I was asked to serve on the Universal Healthcare Commission, and I will say that it's kind of lonely on there because most of the people on there have already decided that this would be a good thing. And I keep questioning and pushing back and saying I'm not certain that this would be a good thing. Now, there's currently a bill. So anyway, there was another bill, a second bill now to form the commission, which I'm on. And there is a current Senate bill by Senator Hasagawa to move to a single payer system and start the process formally to move us to that. It hasn't gone anywhere, but it's out there and it could be moved at any time.
Well, one of the questions I have is there's been reports now, Colorado and Vermont already have tried statewide single payer, and those both have failed. So why would this one be any different?
We and they would tell you we've learned from both of those instances. And Colorado's was actually on the ballot, and the people rejected it. In Vermont, they tried it, and they found that they couldn't control the costs,
Mhm.
and they abandoned it. But we're in Washington, and we do things better, and we can figure it out. And that would be what proponents would tell you, that's what they would say.
So it's the cost side that just having more insurance doesn't do anything about the costs or controlling the costs. And I had an interesting experience in 2017. I've been out of the health insurance market pretty much since 2014, because we couldn't find for two self-employed people, we couldn't find health insurance that was affordable. So we joined a healthcare sharing ministry. That's been fine. It has given me some insights into how health insurance works. That's a little different, but relevant to what I was just going to say is I had an experience where I took a fall, torn rotator cuff, fairly straightforward injury. Talked with my doctor. I needed an MRI so that they could figure out what needed to be fixed. She gave me the diagnosis code, the CPT code, and I called 6 hospitals, sources for that MRI in the area, including Northwest Specialty Hospital and Kootenai Outpatient Imaging, so Coeur d'Alene and Post Falls, Inland Imaging, Lincoln Hospital, Whitman Hospital, and Deaconess Hospital. Got quotes from all of them for what it was going to cost for that CPT, for that particular code. The cost was going to range from $578 to $3,405.
Isn't that amazing?
No rhyme or reason, really.
Right.
I went to Post Falls.
Right.
It's worth the drive.
Well, I get that. And did you have any problems with the sharing ministry and paying that?
No, I had no problem.
See?
One of the ways that the sharing ministry works is that it's people who are committed to trying to keep their costs controlled, and because there's a commitment to the group, and so because it's a self-selected group, so that the psychology is a little bit different. The economics work out differently. I've never had any problem with any issues that I've had to submit for sharing. And it's a model that doesn't necessarily work for dealing with chronic conditions. It works very well for taking care of everything ordinary that you pay out of pocket, and for what you submit for sharing, for something that's over $500. So it works for that. But I recognize that model doesn't deal with some of the tougher questions, which is people who have an unfortunate chronic condition that requires some maintenance on a regular basis. It's quite expensive. That's a very different kind of problem. I think most people would agree that yes, we should sharing those kinds of costs as a society is one thing, but then and then letting people self-select into a group is something else. Anyway, it's the cost side that I don't see much emphasis. How is the Universal Healthcare Commission looking at the cost side? Are they just looking at arbitrarily saying we're not going to pay all of it?
What they're saying is, and what they're proposing is that you would pay 160% of Medicare, and that is their baseline. And that is how they're proposing. They're also going to propose that every person would pay I believe it's a 10.8% payroll tax to pay for this universal health care. Their questions now start arising is, does the state have the authority to regulate what they call ERISA plans, which are regulated by the federal government, not by the state? So they bypass the state. And the question is, and that has not been decided by the court. There is an assumption made by this group, I'm on the commission, that they're going to be able to tax these folks to help pay for the universal health care. And you back to the cost, and we can tease this out. I can tell you what the majority party is proposing, or what they've got cooking, so to speak, to control costs. All the models that we have seen, and if you go into the work groups, their proposals, they claim that they're going to save, it's a couple percent. but a couple percent is close to $1 billion. And I pointed out in my comments about the work group report is that I use when we did expansion of Medicaid, we were going to, after 5 years, they figured we would have 328,000 new people be enrolled in that. After 3 years, we were well over 500,000 and not even the 5-year time period. So my point was the consultant's best guess, and that's what it is, was way off. And my comment that I believe I wrote in that report was, I am unwilling to throw such a large part of our sector away on the anticipation that we're going to save a few percent, because basically I said, I don't believe you. And I listed that instance to prove that. I mean, their numbers were so far off, but yet we based all our budget assumptions on that 328,000. We blew past that and went way beyond that. And the numbers are way, way beyond what we ever anticipated. So the consultants aren't always right. And I believe in my mind, it was too big of a gamble to throw away this system that we currently have with its flaws. I'm not saying it's perfect, on the promise or thought that we were going to save money on the other end. I don't believe it.
Has the Universal Healthcare Commission, as you're looking at the options that are proposed, is there now a range? Have they learned from that? I mean, it is an estimate. Estimates should have a range, though. Is there any kind of worst case scenario planning? We think it might be this, but it could be like this.
Unlike when we do budget forecasting for the state and the state economists, they give a good scenario, what they think is going to happen, and then a poor scenario. No, we do not have that. We have only good in proposals as we move ahead with this.
That doesn't give me confidence that there's been learning from past mistakes.
Well, I pointed it out, and when I was so frustrated at the last meeting, I literally stopped and said, do you really believe that people with their distrust of the government are going to be willing to allow the government to run something as personal as their healthcare? And the response was, we'll earn that trust. We'll earn their trust. And that's all they said. And so
how did anybody have an idea how? Because the trust in public health is about.
It is going to be so good. Like I said, there's some fundamental beliefs that are in challenge here, and I will speak freely. A lot of my people that I serve with on the other side of the aisle believe that the government, I'm going to be overly simplistic, can do no wrong. The government is good. Growth of government is good. I'm on the other end of the spectrum that said, I don't believe there's much good that the government can do. And they struggle at keeping the wheels under the trains and the trains running on time. And we have a track record of that. And we could talk all day about all the shortcomings of government. And I just don't believe that there's going to be a willingness by the public to want to embrace this. And so there are some very fundamental differences and flaws that I keep bringing up to the universal health care.
So that payroll, how does that payroll tax work for people who don't have, I mean, I'm not on a payroll, right? I'm self-employed. My husband's self-employed.
I think that there's a lot more details. This is just a thumbnail sketch. This is their proposal, how they're going to pay for it. There will be a report to the legislature. I think it's going to be due by the 1st of December, and they will explain in there that, but it is a payroll tax, and it will have to be as broad as possible to be able to pay for this. Another misnomer that, if I could, please, is this idea that the doctors are going to be totally in charge of everything for your care, which is a novel and a great concept. We'd all like to believe that, but there is not any universal healthcare system operating in the world that doesn't have a board overseeing it said, this is what we're going to do and this is what we're not going to do. So I believe that they're putting forward false hope and telling people, well, your doctor's going to be in charge and you're going to get the latest and greatest and everything. I don't think that that is correct. I think that's not shown to be the case anywhere else in the world that has embraced a single payer system. And I think that by doing this, you are bringing false hope to people that this is going to be the end all beat all and wonderful. Now, the other side of this, another thing that they have not even talked about. If I'm a doctor and I've come out of medical school and I've been to school for 8 years and I have accumulated debt, with the universal system, we are limiting what you are paying to 160% of Medicare reimbursement. If I've got more debt and I have a better opportunity in a neighboring state, what do you think is going to happen to that doctor? Well, he's not going to stay. He's out of here. And to put himself into a position where he can better take care of his debt, his family, and his career. And I've also brought this up in my comments that means that we're going to have to pay for all the doctors then as a state. And then we're going to also require you, okay, since we paid for your schooling and paid for this, this is all you're going to get paid. And I just don't believe that will be the case. Maybe I'm naive, but I think that people will make the best decision for themselves. And they will go where they need to go to be able to practice, to be able to see a future.
I think that problem in part speaks to how the whole Medicare for all, Medicare reimbursements I don't cover costs, right? So it was a real hit to the rural hospitals when the ACA came into effect, the Affordable Care Act, because they lost the ability to recover on cost. And because they had a higher ratio of Medicare patients to private pay, Medicare kind of relies on healthcare providers having a higher number of private pay to offset the taking a loss on the Medicare patients. Not that anybody in healthcare seems to know exactly what it costs to provide, but they all have different ways of covering that. So the fact that 160% of Medicare is seen as a reasonable number, I think reaffirms that Medicare rates are not covering their full costs. That's why people can say Medicare is cheap, because it's just deciding not to pay everything.
Well, I'd like to stop here. So just so we're clear, Medicare is the federal program for our retireds and those that are disabled. Medicaid is the state-run program that we are in a 50-50 partnership in the state of Washington, and that percentage can vary depending on what state you're in. But we're basically just call it 50-50. And if let's call private pay 100% payment, and then usually Medicare, the federal program, is around 65%, and then Medicaid, the state-run program, would be closer to 30%. So every single time we pay a Medicaid claim, we're counting on private pay to make up the difference. And that is why you've seen the rates, and the providers, we just have to have these higher rates of reimbursement to make up for the underpayment of the state. It's going to take, in last year's budget, just to give you an idea, the doctors came forward and they said it's going to take about $125 million to move us up to Medicare reimbursement. And in the budget, they got a $9 million increase. So we're still underpayment of Medicaid, the state-run program where we get to choose how much we're going to reimburse. And that continues, and that's a big part of the reason why we continually have very high private sector rates to make up the difference.
That cost transparency has come up. In fact, it came up in the last presidential debate. Nikki Haley spoke to that as a way into this tangle that we have, that's not a very systematic system, and getting some transparency into rates so that you can say we're not, well, she used the example of her mom being offered Tylenol in the hospital and being told, you might as well take it. You're paying for it, 2 Tylenol for a couple $100 or whatever the charge is.
Right.
That transparency, that actually is another thing that I have gotten a little better, not full insight, but I have to tangle with a sharing ministry, is that I'm doing my own negotiation. And when I was getting all of those costs, I got their base cost and I got what they would offer as a discount. Now I know I'm not getting as good a discount necessarily as the insurance company. But you can ask for a 20% discount. You can ask for a 30% discount. That always makes you wonder if there's a retail rate, there's a wholesale rate. Does anybody actually know what this costs to provide the health care? And has there been any other conversation about trying to get into that health cost transparency?
Well, let's talk philosophically for a moment about that. If we had everything that was open and you could see everything, what would we do with all that data and information? That's my first question. And then the second, I keep asking this question. I don't know the answer. I'm not Solomon here, but in the healthcare system, your biggest component is labor. And I would ask, who doesn't get paid? In that system, who won't get paid or who doesn't get paid? You just saw some pretty big increases for the nurses that we are short of. And they've got a pretty big contract over at Virginia Mason over in Seattle. Well, what do you think all the other nurses around that area are going to want in their contract? Well, they're going to want the same thing because that's the market now. They've set the market in that. Okay. And I don't want to, if I'm in the hospital, I want good nurses and want them well paid so that they're not disgruntled and not taking a good care of me. But again, I pose the question, and this is part of the dilemma. It's the healthcare system is not what I wish I could change it and make it. It is what we have now. And I go back, who doesn't get paid? Now, the Democrats, and I'll be pretty blunt, they think that the administration just makes way too much money, and there's millions and millions of dollars there to be had. Well, I'm not going to disagree. Sometimes the numbers do seem outrageous, but there's a lot of responsibility also by those administration in trying to make all of this work, negotiating to keep the wheels on, so to speak, at the hospital and to keep them operating. It's a challenge. And I'm not going to say it isn't, because it is. You look at the hospital system right now, and overall, boy, our system is not in very good shape. And I actually am working on a couple pilot programs. Now, in this area, I am really concerned about my critical access hospitals in my district. I have 8 of them. And I am worried about the future and how they're going to be sustainable in the future. And I've talked to Kathy's office too about this, and even she had people I talked to from back in Washington D.C. and they keep asking, well, you're going to have to cut somewhere. And I just said, I don't know the federal budget, and I don't know areas where we can change. But if we're going to continue to have critical access hospitals operating, taking care of the people that I represent in my district, those hospitals need to be viable and be able to stay, because they're the ones that are taking care of it. And my fear is, or one of them is, and I would challenge people, put a pin in the state of Washington on an old-fashioned map, a paper map, and put a pin in every place where there's a hospital. Start taking those pins out. Now all of a sudden, and we'll use Republic as an example. You take that hospital away at Republic. There's a pass to get in there. Any way you go to Republic, you've got to go over a pass. Right. And how is the care going to be delivered to those folks in that area? And you're past that, they call the first 40 minutes after a situation that golden time, where they want you to be able to get care within 45 minutes. That means the ambulance goes out, comes back in, and transport that. If you start removing these hospitals, where and how far are these people going to go?
Well, I think there's a lot of people that don't recognize how reliant they are on critical access hospitals if they ever leave home. All the people that go attend to concerts in the Gorge has a huge impact in Quincy. Everybody driving I-90 because they're going to go to the lake in Idaho, and they're driving from Bellevue. I had this conversation with an uncle who was wondering, why do we have all these little hospitals? And I said, well, if you have a medical emergency between Ellensburg and Spokane, you're going to be really glad that Ritzville's still there. Has something there, and Ritzville handles a lot of traffic accidents on I-90 and 395, and I don't think people pay that attention. I responded once. I was crossing the Keller Ferry coming back from Ferry County, and I had my pager on, and it went off for a call to the Wilbur ambulance to come down to the Keller Ferry landing, to the marina down there. And I knew it was going to take the ambulance quite a while because there was construction on the Keller grade, and I went over to see if I could help. And so here's people who are out on their boat. They come to Lake Roosevelt on a regular basis. They've been coming over here to recreate, and somebody has done something silly, jumping off a rock, and it was not serious. But as I'm talking to them, she's looking, the mom is looking around saying, so is there a hospital around here? So it's never occurred to her in all the years that they've been there that now she wants one. Well, fortunately, there is actually an ambulance. They've all had to drop work to come to respond, and they're gonna take you to the closest hospital, which fortunately is not that far away. And people are just oblivious to how reliant they are on those critical access hospitals.
And also, I want to thank you for being the years of service you've given as an EMT to your community. That needs to be honored, because our small communities cannot operate without folks like you that have taken the time to get trained and to help their community. So thank you.
Well, I'll put that out as a recruiting pitch as well, because I've told everybody, look, when I hit 70, I think that's a nice round number to retire at. We got to get the next generation coming in. So you guys got 3 years to recruit. So
I understand, but the critical access hospitals do provide a valid service. And, I know that's one of the struggles, that they have in Ritzville. Their census is low. But boy, you have a pileup out there, which does happen.
Right.
And they need that the services that can be rendered at that hospital.
Right. And the helicopters can't always fly.
That's correct. And sometimes the fixed wing planes can't fly either.
Right.
So it's a system but I am looking at some different things that I'm hopeful that we're working on as pilot programs that I think that if they work is something that I think I'd want to take statewide. And so it's not like I'm just sitting here bemoaning. No, I am searching and looking for things that we can do to help these smaller hospitals. And I am working on that actively.
Yeah. And how is the public option going? Because I know there's still, as of the last report that I pulled up, there are still 5 counties, 3 of them in your district, Lincoln, Garfield, and Columbia, that's not an option. The public option is not an option in 5 counties, 5 of the 39 counties. Originally, it was only in 13 counties. How is that working? Is it getting better?
Well, they're saying they're getting more people, but they're getting more people because there's a limit. Again, we're at that 160% of Medicare, and that is the reimbursement level for the public options. So we're forcing government control over the price. And how does that affect, people in the 9th district? I've got 3, like you said, I've got 3 counties. It's not even offered. And yet this is what's being promoted by the Universal Healthcare Commission, that the 160% of Medicare is the end all beat all. And that's where they want to go, and everybody's just going to be happy. Well, I've got people in 3 counties that aren't happy because it's not even available.
Has the commission asked the question, bring in healthcare providers and say, okay, what could the government do that would cut your costs? not just cut your, not just cut what we're going to pay you, but because I know Kathy McMorris Rogers had a meeting in Davenport a number of years ago now when the ACA was fairly new, just getting input. She was just listening. And the one that stuck with me is the woman who, I've known her for a while. Her job at Lincoln Hospital was just to follow the regulations and make sure that they had read all the new regulations as they come out, see how they were going to affect things. I mean, that's part of the administrative cost, is just keeping up with that. So if you brought in all those people, all those Darcys in from across the state and said, okay, what does the state control that we could remove, simplify, reduce its impact on your cost so that you could offer care at lower cost?
No, to answer
Well,
that question,
that would be,
never,
seems like such an obvious question.
well, but unfortunately, it doesn't meet the narrative, Sulani. The narrative is we want single payer because the government can do it better than the private sector. That is the underlying message. And so things that actually work don't bother me. That is not, I could make that suggestion and I think it would fall on the same ears that my suggestions about universal health care is running currently. It just is something that they don't want to delve into, unfortunately. Now, I wanted to get back to it. You asked about cost earlier, not dealing anything with the cost. The Democrats passed there's a fancy name, but it's basically an overcost, or they're going to look at overall trends in healthcare, and they're going to have the authority to fine those that are over. But they've already decided, they've had meetings, and medical trend is what people, that I call it trend, but it's in medical inflation from year to year, so that people have a little idea what we're talking about. And that board has decided that this year, what's allowable for trend or the medical inflation is 3.2%. Well, I know that the individual market rates were released and they're running anywhere from 7 to 13%. And one outlier is at 17%. And that means that's the cost of insurance from the private market to be able, across for the individual market. Okay. Well, that's multiples of that 3.2%. So this board has the authority where they can drag these carriers all in and say, you're way beyond this, and they have fining authority. So basically, they'll have to go to that board and say, Mother, may I, because our costs, and they'll explain this is why our costs are so high, and that I do not, in such a heavily regulated industry as we have with healthcare, how does more government regulation going to control costs? I'm a free market person, and I think that the things that we need to be taking a look at is we need more competition in the marketplace. And remember, I said earlier, it's not what I wish we could have, but I have to deal with what we have. We have 5 hospital systems in our state. You've got Providence and Multicare in Spokane, the Franciscans, UW Medical, and Peace Health. That's it. They, to me, and this is Joe's observation, and I've said this publicly when I've been speaking, they seem to be more content in divvying up the state than competing with one another. So that leads me, I brought up and started talking about, I think we need to take a look at the policy called Certificate of Need and see, is it working? Learn about it. Is there places where we need to keep it? There's places that we don't. I'm looking for anything that are barriers for people to enter our marketplace and to remove as many of those barriers. Now, that's one of the things the government, I believe, should be doing, removing barriers so that we have more providers coming in to our state and more entities that they want to come into our state. Let's not make it harder. Let's make it easier for them to come in and locate and invest in our state. So that, to me, that's one of the things I'm really taking a serious look at in legislation is what are the barriers? It's kind of back to your the lady named Darcy that you were spoke of. What are the barriers that the state, what are the things that we can do? And that's one of the things I'm actively working on, to eliminate those barriers so that we have more providers coming in. We have more people that want to do business here, not fleeing and leaving the state.
I know one of the other cost drivers has always been our what's it called? Joint and several liability, that driving a malpractice insurance rates in Washington. I know I mean, I ended up going to Post Falls for the MRI, and there's two pieces of free market that make a difference there. One is Idaho has lower insurance rates for malpractice insurance rates
Malpractice.
for providers, and that has driven providers to change states where they practice. And the other is Northwest Specialty Hospital is the kind of hospital that doesn't exist in Washington because of the certificate of need process, and which essentially limits the amount of beds. For anybody who's not familiar with that, you have to prove, and that has caused some interesting problems even in areas that are growing where they clearly needed to expand. And I know Swedish Hospital went through a whole bunch of hoops trying to be able to establish healthcare in Issaquah. There's a whole new town there in the Issaquah Highlands, essentially a whole new city that's sprung up, and they're trying to provide healthcare there, and it just took a long time to be able to even provide that, get through that certificate of need process.
Well, a little closer to home, Kennewick General. Early in my healthcare career, they fought and fought and fought, and it took them years. And now they have a new hospital. It's called Trios. It's not new anymore, but that was the end result of that. But it took them years and millions of dollars to fight this. And I'm not sure whether that policy is productive. And that's why I think we need to be taking a look at it. Now, in certain instances, maybe it's working, but I think we need to take a look at it. And I question whether it is in the hospital world. I really do.
Yeah.
So,
yeah. One last thing. I know when I was involved with the Washington Rural Health Association, that debate over specialty hospitals and certificate of need was always really touchy for the rural critical access hospitals, because they're not in a position of being able to compete. In Washington, it's really unusual. Almost all of them are public hospital districts, just like a school district. They are a district serving an area. But there has to be a way to work through that. How do we protect that essential healthcare infrastructure that provides that safety net across the state, and then still introduce some savings in cost and some competition in the larger hospitals which are the backup. I mean, it's a tiered system. You start at the lower level and you work your way into a more critical care.
I think every critical access hospital has done a community assessment, and in that assessment, what they're doing is finding out what the people need in their community, and then they work to recruit and have the facilities to do that in their community. I'll talk about Odessa Hospital. They found out a number of years ago that a lot of people going out of the area to get care. And one of the things they got care for was physical therapy. So they put in physical therapists, they recruited them, had them come in so that they could take care of them in their community. And most every hospital I know that's gone through this process, and I'll use the one in Prosser, which is a critical access hospital. They learned that a lot of people were leaving for surgery, knees, hips, and shoulders. They were going to the Tri-Cities and leaving the area, and then people go back and forth for their follow-ups. So the hospital decided they would try to recruit an orthopedic surgeon. Well, they did. They found a guy in New Jersey, of all places, who was tired of living in a big city, wanted to come to a small town. He came, and now the hospital, which was running in the red, because they're able to do these surgeries in their facilities locally and not having to travel, has put them operating in the black. Now, the majority party, or the Democrats, they don't like that. They want to control where these procedures can be done. And I'll give you an example. If you're in Medicaid and you have a knee, hip, or shoulder, well, you're going to have to go to Seattle to one hospital over there because it's the only one allowed, and they'll pay for your room and board and travel and whatnot. But and so you have to go over there. So how does that affect the people who live in our district, Sulani? That's a long ways. And can you imagine if you went over there and had a hip surgery and then have a 4 or 5 hour ride after that in a car?
Yeah.
That'd be miserable. So the question that I get is that, okay, since the state has set the rate at this amount of money that they're going to pay for Medicaid, if another hospital anywhere, if we're willing to take the same reimbursement, why can't we do it? But see, the state said, no, we don't want to do that. And to me, that just makes good sense. If the state is going to pay the same amount of money, why can't that be done locally and not have to drag people all the way over to the other side of the state? I do not understand that.
Right.
And so I don't think that helps the people in rural areas that need these. Sometimes needs these surgeries just for their quality of life.
I know that our hospital district, and hospital districts have commissioners. They have a board, just like a school board. They have who are very responsive to the local needs, because I mean, I know who they are, and I go check find somebody and sit down and visit with them and let them know what's going on. But yeah, a healthy hospital district is very responsive to and every local community has a little bit different needs because of where they are relative to a larger medical facility and what their patterns of work and retail connections are. All of that makes a difference. In fact, that economic development piece, every time somebody gets shipped out of town for care, they're going to do some other errands while they're there. So that's been a real issue.
Well, and I think kudos to the critical access hospitals. They are doing the very best they can to keep their hospitals viable so they can keep providing the care to their local communities. And boy, some of them I would say are very innovative, and they're doing it and they're working hard at it. And so kudos to the work that they're doing.
Well, I've worked for critical access hospitals as an architect in Eastern Washington, and in fact, I did the physical therapy facility at Odessa, and I've just have found that the staff at every critical access hospital, they're just really focused on how we're going to work with the community. But what actually got me into politics, I'll tell one last story and then let you have the last word. One of a couple of things that pushed me into being politically active was finding that I'm working with a hospital, and they're trying to figure out how to get a place to do a blood draw inside the actual hospital building, part of the building, and not in the clinic part of the building, because if it's in the hospital part of the building, they get to bill at a higher rate. I'm thinking, and that means that these two buildings on this campus were separated by a parking lot. So in the interest of being able to get enough payment back from the federal government to be able to cover their costs, patients have to walk across the icy parking lot. That's dumb. And there were just a few too many dumb instances of trying to solve a billing problem or a regulatory problem at the federal level that with an architectural solution when that wasn't the problem, and I wanted to try and go upstream. So that was really was just seeing too much mess in that.
I bet that was eye-opening to you.
Yeah. After I'd run into a number of those kinds of problems, it's like, this is silly. Well, this needs fixing. It's not fixed yet.
No, and it's something that we often argue about, facilities fees, and that it's not about where can we provide the care at the least expensive place, and still provide the right care. One thing that I find is something for you to think about and ponder. What incentive is there for a patient to shop? look at the range that you found with your MRI
Mm-hmm.
of all the different places, and you called them. There is no incentive to shop, to look for different, and I think I believe the carriers are missing out on this. I'll give you an example. I had a hip reinstalled in one of my hips was bad. So one of the requirements was an MRI. So I went to my local hospital and I said, "How much is it?" And they said, "We don't know." And finally, they dug and dug and dug. And they found out. Well, I found out it was cheaper if I went to Pullman, which I did. So I saved the system money by my shopping, not required to do. And yet, I didn't see any advantage of that. And yet, from a few phone calls, I saved the system money. I think we're missing the boat there. I don't know how it's done, but I think that we're missing the boat when we don't encourage people to shop and take more emphasis of their own health care.
And that's the part that's missing as well as the part that the patient pays. That we all as consumers of healthcare play in maintaining our health and in asking questions. And I know that my doctors actually enjoyed the fact that I was not in an insurance system. Because when I did go in with that rotator cuff, she said, "Well, if you had insurance, we'd have to do this first, and then this first, and then this, and then we could get to the MRI. But we'll just go right to that and get it taken care of." And that saved money as well.
Well, and they did that to protect themselves.
Right.
And I don't blame them. The doctors just, they've got to protect themselves. They don't want an unnecessary lawsuit if there's an issue that arises. And so you're right about the liability and the amount cost of insurance and those issues. That is something else we need to take a look at.
Yeah. Well, thanks, Joe. I look forward to following this issue with you through the next legislative session. We'll see how it turns out.
I will work it and do my part. I'll do my best for the folks that it is very important for me to keep providers in our local communities taking care of the people of the Ninth District. Very important to me. And I have that reputation in the legislature, and I'm glad I do. But we got to make sure that folks can get the care that they need in a timely manner.
And that needs to be the focus.
I agree.
Thanks for joining me.
Thank you. Have a good day.
You too.